Have you ever noticed or maybe, heard someone mention a kind of gradual change in urinary habits as men get older? It's actually super common, something people talk about but maybe don't always fully understand. Today, we're doing a deep dive into something called benign prostatic hyperplasia, or BPH. It's this condition that a lot of men run into as they age, and honestly, it can really affect day-to-day life.
Exactly. And our aim today is really just to, well, demystify BPH a bit. We'll get into what it is, what signs to look out for.
To actual symptoms.
Right, the symptoms. And then how doctors figure it out, the diagnostics and the whole range of ways to manage it. Everything from like lifestyle tweaks to meds, even surgery sometimes. We want to make it clear and hopefully actionable for you.
Okay, let's unpack that. Maybe think of it like this. Imagine the prostate gland is kind of like a donut. And running right through the whole of that donut is the urethra. That's the tube urine flows through.
Okay, yeah. Good analogy.
So BPH, at its core, is basically a non-cancerous enlargement of that donut, the prostate gland. And what happens when the donut swells up?
Well, it starts to squeeze the tube running through it.
Exactly. It compresses the urethra, makes it harder for urine to get out.
And it's pretty amazing, maybe startling even, just how common this whole squeezing the tube thing is. That compression causes real urinary obstruction, and it affects over 50% of men age 60 and older.
Wow, 50%. That's huge.
It really is. Half the guys in that age group. And it's not just, a small nuisance. It's actually the second most common reason older men have surgery.
Second most common.
Yeah.
It really hits home how much it impacts quality of life. It's not just an annoyance then.
Not at all. It goes way beyond that.
Okay, so we get the internal picture, the mechanics of it, but what does it actually feel like for someone? What are those signs, maybe subtle at first, that might make you think, maybe I should get this checked out?
Right. BPH usually shows up with symptoms falling into two main buckets, really. Obstructive symptoms, things blocking the flow, and irritative symptoms, things irritating the bladder.
Okay.
And these are important clues. They aren't just, normal signs of getting older that you have to put up with.
Yeah, and I imagine they can creep up on you. Like maybe you notice urinary frequency needing to go like way more often during the day.
Frequency is a big one.
And maybe even worse for sleep, nocturia that's waking up, multiple times a night just to pee?
Exactly. That's often one of the most bothersome symptoms. Then there's hesitancy. Difficulty actually starting the urine stream.
Right, like standing there waiting.
Precisely. And the stream itself might change. It could be decreased, weaker, or intermittent, kind of starts and stops.
You might even find yourself having to push, like straining abdominally.
Yes, straining is common too.
Yeah.
You might also feel like you're not really voiding much, a decreased volume, or that frustrating feeling of not emptying completely.
Oh, and dribbling afterwards. That's part of it too.
Yes, post-void dribbling. And just generally a weak stream or that persistent urge to go again, even if nothing much comes out. If any of that sounds familiar, it's definitely worth a chat with your doctor.
Okay, so someone comes in with these symptoms. How do doctors actually pin down that it is BPH and, importantly, not something else? What are the main tools in the diagnostic toolkit?
Good question. When you see your doctor, they'll typically take a few steps. First, often they'll use something called the International Prostate Symptom Score, the IPSS.
IPSS.
Think of it like a standardized questionnaire. It helps objectively measure your experience. How severe are the symptoms? How often do they happen? It puts a score to it.
So it quantifies things.
Exactly. Then another key test is the post-void residual measurement, usually done with a quick ultrasound right after you urinate. It shows how much urine is actually left behind in your bladder.
Ah, so if there's a lot left, that points to blockage.
Precisely. A urinalysis, just a urine test, is also standard. That helps rule out other things that cause similar urinary symptoms, like a UTI, a urinary tract infection.
Makes sense. What about blood tests?
Yeah, blood tests like BUN and creatinine might be checked to see how the kidneys are functioning, although, interestingly, checking creatinine isn't always recommended right at the start, just for these urinary symptoms unless there are other concerns.
Okay. And the PSA test? That comes up a lot with prostate health.
Right, the prostate-specific antigen test. It might be done. PSA can be a bit elevated with BPH, usually under 10 GL. And this is really crucial if your symptoms or the PSA level or maybe finding blood in the urine suggest something potentially more serious like prostate cancer.
Then it's a different path.
Absolutely. Then a referral to a urologist is definitely warranted for a more thorough evaluation.
Got it. And what about the physical exam part?
Well, the standard is the digital rectal exam, the DRE. The doctor feels the prostate gland through the rectal wall. With BPH, it usually feels enlarged, but typically firm and smooth.
Okay. Any imaging involved, usually?
Sometimes. Things like ultrasound, maybe even a transrectal one, or CT scans, or MRI might be used. They give a really detailed picture of the prostate's shape and size, especially if surgery is being considered down the line. And rarely, if cancer is strongly suspected, a biopsy might be done.
All right, so the diagnosis is BPH. The next question naturally is, okay, what now? What can we do about it? Let's get into the treatment options, starting with medications.
Sure. The main goals with medication are pretty straightforward. We want to improve your quality of life, obviously, help urine flow more easily, relieve that obstruction, stop the BPH from getting worse, and, prevent potential complications.
Makes sense. So what are the main types of drugs used?
Generally, we think about two primary classes. First, there are the alpha-adrenergic blockers, or just alpha blockers.
Alpha blockers, right?
These work pretty quickly. Think of them as relaxing the muscle tissue right at the bladder neck and within the prostate itself. This opens up the channel, improves flow.
So faster relief.
Yeah, relatively quick relief. Common examples are drugs like tamsulosin. Many people know the brand name Flomax or doxazosin, alfuzosin, terazosin, silodosin. They work well for bothersome, moderate to severe symptoms.
Any downsides, side effects?
Like any medication, they can have side effects.
Yeah.
Things like dizziness, sometimes a headache, maybe fatigue, or orthostatic hypotension that's feeling dizzy when you stand up. And one specific thing to know is a risk called intraoperative floppy iris syndrome, which is important if you're planning cataract surgery. So definitely tell your eye surgeon if you're on one.
Good to know. Okay, so that's one class. What's the other main type?
The other main group are the 5-alpha reductase inhibitors, or 5-ARIs. These work differently. They actually target the prostate gland itself and shrink it over time.
Ah, so they address the underlying enlargement.
Exactly. Examples are finasteride, brand name, Proscar, and dutasteride. These take longer to work, months usually, but they can be very effective, especially if the prostate is quite large.
And their side effects. Different from alpha blockers.
Generally, yes. Because they affect hormones related to the prostate, side effects can include things like decreased libido, some ejaculatory issues, or rarely, gynecomastia, which is breast enlargement. Sometimes doctors might even prescribe both an alpha blocker and a 5-ARI together.
Interesting, a combination approach.
And there's actually one more medication worth mentioning, tadalafil, taken daily at a low dose, 5 milligrams.
Isn't that usually for erectile dysfunction?
It is, but research shows it also helps relax smooth muscles in the lower urinary tract. So it can improve BPH symptoms, even if ED isn't an issue for the person.
Huh, fascinating. Now, what about all those supplements you see advertised, like saw palmetto?
Yeah, you hear about saw palmetto, African plum. It's really important to state that based on the current medical evidence, these complementary supplements are not medically recommended. They just haven't been proven effective in rigorous studies for treating BPH.
Okay, that's clear. Stick to the prescribed meds. So sometimes medication isn't the whole story or complications pop up. When does the conversation shift towards surgery?
Surgery usually comes into play if complications develop, things like kidney problems because of the blockage, recurrent bladder stones or infections, or seeing blood in the urine, what we call gross hematuria. Also, if someone has refractory urinary retention, meaning they just can't empty their bladder despite trying meds, or if their urinary symptoms are really severe and just aren't getting better with medication.
Are there different types of surgery?
Yes, there are several options, including some minimally invasive procedures, but the sort of gold standard, the most common and effective primary surgery, especially for moderate to severe symptoms, is transurethral resection of the prostate, or TURBIC.
TURP. Okay, let's talk about that. If someone is headed for a TURP, what's involved? What should they know before and maybe more importantly, after?
Absolutely. Before the TURP, there's a thorough assessment, often using imaging like ultrasound or maybe even cystoscopy, to get a really clear picture of the prostate's size and shape. Patients might get prophylactic antibiotics just to prevent infection. And of course, a detailed discussion about the procedure's benefits and potential risks is essential.
Okay, and then after the surgery, recovery sounds pretty involved.
It is, and managing it well is key. A really important part right after TURP is the continuous bladder irrigation system, or CBI.
CBI, what's that exactly?
It's basically a special Foley catheter that has an extra channel allowing sterile fluid to be continuously rinsed into the bladder and then drained out. This is crucial to prevent blood clots from forming inside the bladder, which could block urine flow.
So it keeps things clear. What should the drainage look like?
This is critical. The outflow from the CBI should look light pink. That's normal initially.
And if it doesn't?
Yeah.
or if something changes.
Right. If the patient suddenly reports strong bladder spasms, like painful cramping, and the outflow stops or turns bright red with clots, that's a red flag. It likely means a clot is blocking the catheter.
What happens then?
The nursing staff needs to know immediately. There's a protocol to manually irrigate the catheter or gently flush it with saline to dislodge the clot and get things flowing again.
Okay, so monitoring that outflow is key. What else is monitored?
Urinary output itself is tracked carefully. You have to subtract the amount of irrigation fluid going in from the total volume coming out to know how much actual urine the person is making. Low output could mean retention or blockage.
Any serious complications to watch for?
Yes, one potential issue, though rare, is 2RP syndrome. It happens if the body absorbs too much of that irrigation fluid during the surgery. Symptoms can include confusion, changes in blood pressure, maybe low sodium levels, hyponatremia. It needs prompt recognition and treatment.
Okay.
Another thing is post-obstructive diuresis. Sometimes, after relieving a chronic blockage, the kidneys can go into overdrive and produce huge amounts of urine for a short period. This needs careful monitoring of fluids and electrolytes to prevent dehydration or imbalances. And of course, standard monitoring of vital signs, pain levels, and overall fluid balance is continuous.
Wow, quite a bit to manage post-op. What about instructions for the patient once they're recovering?
Yeah, important patient teaching includes avoiding sexual intercourse for several weeks afterwards, typically about 6 weeks, to allow healing. And patients should be aware there's a risk of changes in ejaculation, often retrograde ejaculation, where semen goes into the bladder instead of out.
Okay, good to know.
And naturally, providing emotional support and ensuring they have follow-up appointments scheduled is all part of good post-operative care.
Definitely. So, moving beyond the immediate treatments, whether meds or surgery, what about the day-to-day? What practical things can someone do to manage BPH symptoms and just improve their quality of life?
That's a great point. There are definitely lifestyle strategies that can make a real difference. Simple things like encouraging patients to urinate as soon as they feel the first urge. Don't hold it if you don't have to.
Right, listen to your body.
Exactly. Also, advising patients to avoid alcohol and caffeine. These can act as ladder irritants and make symptoms like frequency and urgency worse.
Ah, the usual suspects. What about fluid intake overall?
The advice is usually to drink fluids in small amounts spread throughout the day, rather than gulping large amounts at once. And critically, avoid drinking fluids for about 2 hours before bedtime. This can really help cut down on nocturia, those nighttime bathroom trips.
That makes a lot of sense. Any medications to be wary of?
Yes, definitely. Patients should be educated to avoid many over-the-counter cold and sinus medications. Things containing decongestants like pseudoephedrine or some antihistamines can actually tighten the muscles around the bladder outlet and worsen BPH symptoms.
Oh, wow. I wouldn't have thought of that. Good tip.
It's an important one. Also, just general healthy lifestyle things help regular exercise, managing stress, and patients should always know the signs of a urinary tract infection, UTI, like burning, pain, fever, and report those promptly.
And safety too, right? You mentioned dizziness with some meds.
Absolutely. Safety measures are important, especially watching for that orthostatic hypotension, the dizziness on standing up, or even syncope, fainting, which can be side effects of some BPH medications. Taking precautions like standing up slowly is key.
Okay. And ongoing monitoring.
Yes, for pretty much all BPH patients, an annual checkup, including a digital rectal examination, DRE, and usually a PSA evaluation, is recommended for monitoring how things are going. Though, as we touched on, the broader recommendations around routine prostate cancer screening itself are still evolving and discussed individually.
Right. So when you put it all together, what's the takeaway? It seems like it's about being proactive, understanding what's happening, and knowing there are lots of ways to manage it.
That's exactly it. It's about proactive management and knowing the details, which, kind of raises an interesting question to think about.
Guard?
Well, given how incredibly common BPH is as men age, how does really understanding these specific symptoms, the diagnostics, the effective treatments we've discussed, how does that empower you, the individual, to really maintain your quality of life, to be an active participant in your healthcare, rather than just sort of accepting urinary issues as an inevitable part of getting older?
That's a powerful thought. Moving from passive acceptance to active management. Hopefully, this deep dive gives you the foundation to have those informed conversations with your doctor to take charge of your health or maybe help support someone you care about navigate this.